I mean, charity would be fantastic.
Standing room only. So seats up here. If anyone wants to talk here, there are some seats. And thank you for figuring out that location this way today. So it's a pleasure to get to introduce Vikram Patel and Shekhar Saxena today. As is well known here, in 2007, the Lancet published its own first series on global mental health, calling for the scaling up of global mental health services on the principles of the right to evidence-based care and the right to dignity. Such advocacy influenced the funding and ultimately the implementation of novel approaches to global mental health care, and would ultimately intersect with the articulation of the UN Sustainable Development Goals and the adoption of the WHO's Comprehensive Mental Health Action Plan. Despite such advocacy and action, again, as is well known here, global mental health will remain both absolutely and comparatively neglected, leading to the present Lancet Commission on Global Mental Health and Sustainable Development, which continues to frame mental health as a fundamental human right. In anticipation of the launch of the Commission's report, we're honored to have two of its key authors, along with, I should note, Dr. Kleiman from our department, who's also one of the authors, to present on its key findings. Vikram Patel is the Pershing Square Professor of Global Health in our department, Adjunct Professor and Joint Director of the Center for Chronic Conditions and Injuries at the Public Health Foundation of India, an Honorary Professor at the London School of Hygiene and Tropical Medicine, and co-founder of the Center for Global Mental Health in 2008. He's also the co-founder of Sangha, and we had the opportunity to hear about Sangha's vision and work in closing the mental health treatment gap for young children in India in Gauri Divan's excellent talk here almost exactly a year ago. Vikram has an impressive co-presenter here today, Shekhar Saxena, who both received his medical degree and conducted his residency at the All India Institute of Medical Sciences, and was the director of the Department of Mental Health and Substance Abuse at the WHO, and the joint leader of the Mental Health Innovation Network. His current responsibilities include the implementation of the WHO Comprehensive Mental Health Action Plan, and like Dr. Patel, he's been a key figure in the multiple Lancet series on global mental health from the beginning. This year, we're fortunate to also host him as a visiting professor at the Harvard T.H. Chan School of Public Health. So together, Dr. Patel and Dr. Saxena will give us a real sneak preview of the key messages of the forthcoming Lancet Commission report on global mental health and sustainable development. So thank you so much for being here today.
Thank you, Scott, and thank you all for coming along. To be honest, this is definitely a sneak preview because actually the Commission will be launched. I'll just wait for that's the. So the Commission will be launched on next Wednesday, and we'll tell you a little bit more about the launch. So this is actually like the home crowd, and we're hoping that we'll get some interesting discussion going. I think this is probably a more friendly audience than some of the ones that we will face. And this is also a work that has taken 3 years to produce. Some of it, with all these commissions, not a lot of it is new, but I hope that some of it will also present a fresh way of thinking about mental health that might lie at the heart of some of the recommendations that you would hear about. So the way we're going to do this is that I'm going to start by giving you a preamble about why we needed a commission and what the guiding principles are. That's what excites me greatly, are the 3 fundamental principles in which action has been, around which action has been framed. In fact, we consider this a reframing of mental health going forward. And then Shekhar will take us through the recommendations of the commission. And then we want to end by giving you a snapshot of some of the public engagement work that we have been working on for the last 3 to 4 months, ending off with an animated video that will be launched next week, amongst many other products that we have, including 6 animated videos prepared by slam poets, young slam poets from around the world, etc. So this is not just a scientific report, but it's actually part of a much broader global campaign to really reassert the importance of mental health as not just central to our future as individuals, but I would argue even to our very humanity as a society. So I'm going to start by really posing the question why we need a commission. And I can see some people on the corner there. You can always come here. There's an empty seat here as well, and you can just come up here, and I'm sure we can. There's also some seats here on the ledges. So why we need a commission? Then, as I said, the three different principles that underlie the reframing of mental health. For some of you, they will be novel. For others, it will be a repackaging of what I think many of us have already had strong views about. And the final piece will be the response that we need to make collectively, and Shekhar will be talking more about that. So I want to start with a potted history of global mental health. I think it's important to remember that we are standing on the shoulders of, to use a metaphor, giants, work that have happened over the last 20 years. But as a potted history, I want to start with recognizing, first of all, that this department actually is the home, in many ways, of much of the original thinking around this field through this landmark book that involved many departmental, well, in fact, three former chairs of the department, Leon Eisenberg, Byron Good, and Arthur Kleinman, for those of you at the back who can't read, can't see the title of the book. World Mental Health, for me, certainly was a very defining book. In 1995, I was working in Zimbabwe, and I remember when the book came out, it was an incredible new way of thinking about mental health beyond mental illness. Shekhar led the World Health Report in 2001, and I think this was the first time in the history of the WHO that the annual World Health Report was dedicated to the subject of mental health. Shekhar and I then jointly led the Lancet series, the first one that really established the word global mental health and really positioned what we now describe as global mental health as a discipline of global health. And I continue to see this as a discipline of global health rather than a discipline of one of the clinical mental health areas. Although, of course, those are very central, but we are essentially within the umbrella of global health. In 2011, the NIMH-led Grand Challenges in Global Mental Health was published in Nature, and that was another, I think, a formative event because this really opened the door to a vast body of implementation science that has really led to the Lancet Commission's recommendations in many ways. And then in the same year, I think it was the year after, I can't remember, 2013. Oh, sorry, 2013, again, Shekhar led at the World Health Organization the Comprehensive Mental Health Action Plan, which is an agreement by all the nations of the world, I think, at the World Health Assembly to really, for countries to commit themselves to very specific actions. And as we progress down this timeline, we've seen more and more nuancing and refinement of the global mental health agenda, and that is really where the Commission positions itself really 10 years after the original Lancet series. This is probably the foundational event, 2015. The Sustainable Development Goals, all of you know what those are. Many of us are trying to connect the health areas that we are passionate about with the SDGs. Of course, health is just one of the many goals in the SDGs, goal number 3. But within that, for the first time, this transformational vision of development, transformational because the MDGs were very narrow. There were 8 goals. In the health area, they focused only on a few conditions that were particularly important for developing countries. The SDGs are truly global. They affect all countries. And the health goal, for example, reflects that by including non-communicable diseases and, very importantly, mental health in 3 of the different health targets. But of course, mental health is also intimately associated with many of the other SDGs, and the Commission report speaks a lot to that, and Shekhar will as well in the recommendations a little later. So I don't want to read this, but this is just to show you these are some of these copy and paste are actually from the Lancet report, just to illustrate some of the actual content of the Commission. But here you can see the targets 3.4, 3.5, and 3.8 are the ones that specifically refer to mental health. Target 3.4, interestingly, talks about prevention and treatment for NCDs, but in the mental health area, it talks about promotion of mental health and well-being, and I'll circle back to that later. Target 3.5 is particularly about substance use conditions, alcohol, and other harmful substances, and target 3.8 is referring to universal health coverage. Okay, so this is the part of history. What's the challenge? Well, let's first examine the challenge in a number of different ways. The first challenge is that mental health problems as a burden of disease is increasing in all countries of the world, no matter how rich or poor they are. And here you can see between 1991 and 2016 the relative burden according to in countries categorized according to how developed they are. The red bar, the red line being the most developed countries in the world, and the blue line being the least developed countries in the world. You can see an incline in all of these countries. And if I have to summarize the overall change, it's about 50% increase in the past 25 years. Why is that the case? That is the case because of the very unique epidemiology of mental health problems, that they basically have their onset in youth, basically in late adolescence and young adulthood. And so why is that an important driver of the increasing burden? That's because much of the world is actually aging in two different sections. The first aging process is happening from childhood into youth, and you see this dramatically in sub-Saharan Africa and in South Asia. And the other kind of aging, which of course is related to neurodegeneration, is happening in the rest of the world, which is aging into the older adult age group when you start seeing the onset of dementia. So it is these two powerful demographic transitions that are actually fueling a lot of the changing proportionate burden of mental and substance use disorders globally. And we are seeing mental health problems emerge now in the news all the time as very lethal conditions, something that we haven't always acknowledged. Here is one example. The Lancet Public Health published this last month. It's not just the leading cause of death, suicide is not just the leading cause of death in young married women, but actually it's the leading cause of death in young people in India today. Between the ages of 18 and 40, it is more likely that a young person will die because of suicide than any other single cause of death. This was the truth in China as well, and it would be fair to say, hello Byron, it would be fair to say that suicide is actually one of the leading causes of death in young people globally. And that is something that we haven't always taken account of. The second cause of death, which I think is very close to our hearts here in the US, is the fact that opiate overdose is now the leading cause of death in young Americans. Alcohol abuse is the leading cause of death in young Russians and East Europeans, etc. So oftentimes we think of mental health problems as being something that is intangible, something that doesn't kill in the kind of way that more tangible health concerns are associated with. But actually, when it comes to youth, mental health problems kill more young people than any other cause of death. And this is true of all countries of the world, albeit for different reasons. And indeed, you can see that one of the reasons why we don't often count the mortality associated with mental health problems is because the way the global burden of disease counts the causes of death, it attributes the death to the most proximal cause. So for example, if I was a heavy drinker and I died of cirrhosis of the liver, the cause of death would be cirrhosis of the liver, not the fact that it would not have happened if I wasn't actually drinking heavily. Similarly, suicide, quite bizarrely, is not counted as a cause of death for mental health problems. You died because of suicide. So when we asked the GBD group that looked at mortality to recompute the causes of the numbers of deaths that were because of risk factors associated with poor mental health, that is to say the excess mortality that occurred in people with mental health problems, and of course that includes substance use problems, the actual numbers that they arrived at was nearly 14 million deaths each year. So I keep reiterating this because much of the conversations in global health have focused on mortality, which I think we all agree is extremely important. If you can avoid a death, this is a very important goal. But these are all, to a large extent, avoidable deaths that occur in the prime of your life. That is to say, between the ages of 18 and 50. The other important point, a challenge that we should draw attention to, is that there is a dramatic increase in some of the social determinants. Of course, there's also been an improvement. We should have a balanced view on this. The fact that huge sections of the population have moved from being absolutely poor to being outside absolute poverty is something we should celebrate. There's almost no doubt that that is a very beneficial a social determinant on one's mental health. But there's also all these other kinds of disadvantages and social determinants, some of which show no sign of reducing, and others which are actually increasing. I should add one thing that we haven't shown on this slide, which we should because there's some dramatic images of that, is inequality. There's some terrific images that have just come from Mumbai, but actually this could also be said of Boston, is how, in fact, there are straight lines that separate people who live extremely well-off lives with those who live in very deprived circumstances. And inequality as really fracturing the social fabric of society is another important driver of poor mental health. And then we've got the economic burden. Colleagues like Dan Chisholm, as well as David Bloom at the School of Public Health, have computed the impact of mental health problems, in this case particularly mood and anxiety problems, the most common causes of mental ill health, on both lost work and lost economic productivity. Now, with all this evidence on burden and impact, how are countries doing when it comes to investing in mental health? Well, not very well. Here you can see the years lived with disability, which is a global burden of disease metric. For low, middle income, upper middle income, and high income countries, you can see, for example, it ranges from about 25% to just about a third of the overall burden of years lived with disability can be attributed to mental and substance use disorders. So let's now look at how these countries are actually investing in mental health by looking at the fraction of the overall healthcare budget that invest in mental health. And I must thank Chudling, who actually did these earlier analyses. And you can see that it doesn't really matter in which country you're in. All countries systematically underspend on mental health when you consider the overall burden of disease due to mental health problems. In fact, as I'm sure Shekhar will talk to earlier, the truth is, when we talk of global health in many contexts, really it's just simply a euphemism for what we used to call international health. It's still very much focused on people out there in developing countries. But actually, what you can see here is there is one subject of health that unites the world in terms of injustice. It is mental health. So I really do think that mental health is a true global health subject, because all countries, and this I'm borrowing from Shekhar's line, are developing when it comes to mental health, and this one is no exception. Now, when we look at development assistance, this is the sort of money that rich countries give to poor countries in order to support their health system. You can see here the dollars in million per DALI, that is the burden of disease for HIV, malaria, TB, and maternal health conditions. Of course, these are very large bars because these were the MDG targets. And it's good to know that the world did respond to the MDG targets, and hopefully you will now see a similar response to the SDG targets. And you can see that in contrast, when it comes to non-communicable diseases and mental and substance use disorders, there's no mouse click that's going to show you a bar, because actually that is, in fact, the real figure. It doesn't show up when you scale the chart against these infectious diseases. So we spend very little on our own people, and we spend very little on those who live in the poorest countries of the world. So what is the consequence of this systematic underinvestment in mental health? Here I'm going to show you a chart that these are all from the Commission. I'm going to show you a chart that reports on what is the proportion of people in different countries of the world, organized according to whether they are developing or low middle income countries or high income countries, who receive minimally effective care. This is important. It's not just receiving a single session of psychotherapy or one prescription of an antidepressant medication, but actually receiving it in the way that trials actually demonstrated you need to receive it in order to realize its full benefits. So what proportion of anxiety, depression, and substance use affected patients receive minimally effective treatments? Well, let's look at the poorest countries in the world. More than 95% of people have not. This must be one of the largest unmet needs for care for any health condition globally. Now, rich countries, of course, enjoy much more by way of resources, and let's see how well they perform. Well, it turns out they perform much better. This is not surprising. But consider this, that even in the richest countries of the world, more than 80% of people with mood and anxiety problems and nearly 90% with substance use problems do not receive minimally effective treatment. This is in spite of spending maybe 1,000 times more than the poorest countries of the world. This is an important point to keep in mind, because it isn't the case that simply throwing more money at the problem is going to solve it. If that was the case, we should see much better results here. There's also something wrong with some of the paradigms that have been used for mental health care, which we need to address. And then, of course, you have, as Arthur has very eloquently written about, another horrific consequence of the systematic undervaluing of mental health is these sorts of images. These are mainly taken from mental hospitals in the global south, but I wanted to include this image, which is from a US prison, because the truth is that although these sorts of horrific human rights abuses no longer occur in a hospital setting in countries like the US, they now have simply shifted from the hospital to either the street or the prison. So we need to reframe simply because in spite of this mountain of evidence, the world simply hasn't responded in the way that it should. And I've already mentioned the next point. And I think very importantly, we need to go beyond a narrow biomedical framing of mental illness. We need to go beyond the treatment gap, which is a word that, in fact, we use a lot in the first Lancet series. And we need to recognize that we actually need to redefine treatment as care, which goes beyond just biomedical approaches, but a much broader understanding of the needs of people with mental health problems, and quality, which of course has been written about a lot in recent times by colleagues at the School of Public Health. And of course, also recognize, and I'm delighted that Myron is here, for example, that we have an enormous evidence on prevention. And we have undersold that evidence, mainly because prevention doesn't happen in the health sector when it comes to mental health. But we will need to recognize that we do have ideas about prevention, and we haven't communicated those effectively enough. And so we need to go beyond just reducing the treatment gap to being more ambitious and aspirational and saying we can, with the knowledge we have, do something to actually reduce the burden. In the same kind of way that, let's say an oncologist, a cancer expert wouldn't be just satisfied saying, I want to, improve access to, cancer treatment. No, I would only be satisfied if the incidence of cancer reduced. And we should be far more aspirational in the mental health field by saying, yes, we do have the knowledge, but we aren't doing much with it. So I'm going to now finish with the 3 guiding principles and then hand over to Shekhar. There are 3 guiding principles that have been at the heart of how we think we should reframe mental health, and I'm sure Shekhar and I would be very keen, especially to hear from you about these 3 principles. The first principle is to reject and move away from a narrow binary biomedicalization of mental health. Let's be honest, in most places when you use the word mental health, most people really think you're talking about mental illness. And this is for good reason. It's because that's how the word mental health has often been utilized. We talk about mental health, but actually we could immediately flip over into talking about the treatments for mental illness. But we need to recognize that there is no way to carve nature as its joint when it comes to mental health. We're talking about a dimension that extends from wellness all the way through to psychosocial disability, and that each of us at any given point of our lives is somewhere on this spectrum or dimension. And the goal for each individual, each human being, is to move to the healthier end of the spectrum by using interventions that enable us to do so, but as it were, appropriate for where we are on that spectrum. And so you could use the words promotion, staying well when you are well, prevention for when you have the early signals or symptoms of distress, to remission to when you are actually having a clinically significant disorder, and recognizing that there are some individuals for whom cure or remission is not the goal, but actually social inclusion is the goal. People who actually have enduring disabling consequences of mental ill health. And in doing so, you are able to unify all these different narratives into one dimensional perspective. Now, we also in the report talk about how that would practically be delivered using a stage model of mental health, but I won't go into that right now. The second is to move away from this very, I consider very naive distinction between nature and nurture, and recognize that we know the science tells us very clearly it's both. And how is it both? Well, in this chart, I'm going to show you it's again a very potted account of a very complex subject, but to try and summarize what we call a convergent understanding of mental health and therefore also mental illness. So our genes clearly define, as it were, the canvas in which our personal stories will be painted over the course of our lives. But then there are very important neurodevelopmental processes which we now know far better than we did even 10 or 15 years ago that help us explain a few very important aspects about mechanisms. The first important, and again, apologies for those who are neuroscientists, this is a very simplistic demonstration because this is also to communicate to broad audiences, including generalists. The first important piece is plasticity. We now have amazing rich evidence about how responsive the brain is to the environment, both structurally and functionally. And this is most in the first 2 decades of life, but particularly the first 10 years of life. The second is we also now know that during the phase of adolescence, there are 2 complementary processes in brain development that are happening. One is there's a reorientation of connections in the brain, something that is called pruning, which is basically literally like pruning a tree. Many connections are actually pruned down, and at the same time, different parts of the brain are maturing in a different way. And I won't go into details. Suffice to say that we now know that impulsivity, risk-taking, and thrill-seeking are part of being an adolescent. They are not pathologies. This is actually a normative evolutionary aspect of human development. And the third process is, of course, cell death. Actually, cell death occurs right from the beginning, and pruning is a good example of of cell death. But in the way that we understand senescence of the brain, that is to say, reduced volume and density of brain connections, this clearly accelerates as we go later into life. So you can see these three developmental processes, and we know that the environment is critical because the brain is constantly in this developmental game actually interacting with the environment. It is shaping our environment and being shaped by our environment. So this is rich science, comes from both animal studies as well as human studies. Now, if I had to superimpose on this when mental health problems occur, it's pretty remarkable that they actually occur exactly at these developmentally sensitive phases. So it isn't an accident that most mental health problems begin in youth, nor is it an accident that most neurodegeneration begins in older age. And so this is what we call the convergent view, the idea that neurodevelopment actually allows us to merge findings from social determinants, from neuroscience, etc., to have an understanding of the reasons why mental health problems emerge when they do. And the final guiding principle, of course, very heavily influenced by the disability movement, is the rights-based approach. And here we talk about three key rights: the right to be protected, and this is extremely important for those who are facing risk factors like refugees, people escaping conflict. They have the right for their mental health to not be harmed as a consequence of their. We may not be able to stop the war that displaced those populations, but they do have the right to make sure that the harmful effects as a consequence can be mitigated. And then the next two rights are really largely for people who already have mental health problems, the right to receive care, and for people with psychosocial disability at the extreme end of that dimension, the right to dignity. The right to dignity, and I would add to that the right to freedom in many countries of the world. So how? I'm not going to say much about that. I just wanted to emphasize that we actually in the report have a huge amount of information about the how. We start with actually, acknowledging that the mental health care field has done some of the most innovative things that the rest of medicine can learn from. Recognizing, for example, that deinstitutionalization, the move from hospitals to the community, was actually championed by mental health colleagues way before our time. And that is something that is unique in medicine. The fact that we involve families and patients in planning services is also unique. Very few branches of medicine have actually done that, actual co-production with people with a lived experience. Seeing social interventions as an integral part of mental health care is another really unique innovation of the fields of clinical mental health practice. And of course, person-centered care, focusing on comorbidities, coexisting medical, that is to say, physical conditions and mental health conditions. So I think we need to start with a nod that mental health care professionals have actually often been incredibly innovative. The tragedy, of course, is that other aspects of our practice has really held back the opportunities to reach these innovations to large sections of the populations. And those innovations that we summarize that come from the last 10 or 15 years of new science, psychosocial interventions by non-specialist workers is one that excites me personally. The fact that we now have huge evidence on how empirically supported psychological interventions can be delivered by a range of different providers, widely available in every country. Digital tools, I won't say much about that, except that I know all of us are very excited by the prospects, but of course there's still a lot of work to be done to ensure these are used safely. The balanced care model, that is to recognize using the dimensional spectrum, so that not everybody needs to see a specialist, but there will be some people who do. And therefore, having coordinated balanced care models that achieve the goals of the full dimension of mental health is something that we should be aspiring to in a population-based model. And finally, engaging people with a lived experience and communities to increase demand and accountability. The platform of care is, of course, comes from the disease control priorities volume, which really looks at essentially the delivery of this kind of approach across these different platforms in a coordinated model. and this is my last slide, and I'll give it over to Shekhar now. And I'm not intending you to read this, but in the report you can see we spent a lot of time thinking of which interventions we believe have sufficient evidence to be scaled up in low resource, medium resource, and high resource settings. Remember, see, we're no longer using the word countries. And this is actually another very important shift in our thinking, is that we think these settings occur in all countries. And so it isn't whether a country on a national level is rich or poor, but it's really how well every community in that country is being resourced. And so I'm sure all of you who work here will know that there are settings just like this in the US as well. And so we're looking at establishing certain standards of care, and very importantly, not just clinical care, but also interventions for promotion and prevention. Shekhar.
Thank you very much, Scott. Thank you, Vikram, for explaining. I'm privileged and pleased to be here and presenting some of the findings that the Lancet Commission presents. This is a work by 28 people. I'll show you their names later on and their faces over 3 years' time. So it's obviously taken a lot of effort to do that. But what does it mean finally? What's the audience for Lancet Commission? It's a diverse group of people that we're targeting, but in our mind, the first audience is policymakers. If they listen to the conversation, if they get some of the basic messages about reframing mental health, they see it in the right way, and if they are willing to do something more about it, that's what is going to be an indicator for success for all the efforts that have been made. And with that in mind, the primary launch, the first launch, we'll have several launches. The primary launch is in front of ministers in UK a week from now, where we believe about 40 ministers are going to join from high, medium, and low-income countries. And hopefully they will go back convinced that they need to do something more about mental health. The Lancet Commission makes 7 recommendations. The first one, reframing mental health within the SDG framework. Vikram explained extremely well, so I won't go into detail of that at all. We would like to see mental health as an integral part of health, but also as an integral part of development itself. And that's the reframing that we really need to emphasize, so that it doesn't remain alone the responsibility of Minister of Health. In fact, Minister of Health should actually be arguing about why mental health should be given more importance to his or her colleagues in the finance ministry, in the education ministry, in many other ministries, and that's the kind of message that we want them to get. Having just referred to the first recommendation, I would come straight back to the 7th recommendation actually, which is to strengthen monitoring and accountability. If investments have to be made, we need to monitor the situation and we need to have accountability as to how these investments are being used. Right now, WHO, as an organization, I worked in WHO for 20 years' time. I'm no more working actually now there. I'm based in Harvard now. Has led the accountability and monitoring mechanism, but we believe and we are recommending from the Lancet Commission that it has to be much more independent and it has to be much more comprehensive. So those are issues that the Lancet Commission very clearly goes for. Obviously, accountability will be more important when there are more investments. Right now, as Vikram showed, the investments are actually very poor. So we're hoping for both better investments and better accountability. For the rest of the 5 recommendations, I will have a slide each to talk about that. The first very clear and practical recommendation is that mental health is and should be an essential component of universal health coverage. You're all aware that universal health coverage is one of the goals within the SDG under the health. We are also aware that WHO has kept universal health coverage as one of the top 3 priorities for the whole organization. And a very large number of countries have accepted the principle of universal health coverage as a guiding principle for their health policy. And we just want to make sure that when they plan their universal health care policy, they do not anymore forget mental health. That's the objective of this. This is also one of the calls from the 2007 Lancet series of articles. We believe, as Vikram has just now explained, that delivery of care should be possible with task sharing all along the health system, and use of technology can facilitate and enhance care. This particular recommendation, which I'm presenting in one slide, is actually quite a long passage in the commission. So I would very much request you and suggest to you that on 10th, when it comes out, you spend a little time reading that, which is very clear practical guidelines as to how countries can actually do something about it. The second recommendation, which is quite important, especially from the dimensional aspects, is protecting mental health with actions on social determinants. And that's where it's the whole of the government, all sectors which need to be involved, because majority of these are outside the health sector. So we do know that alleviating poverty actually has a beneficial effect on population mental health. We know that promoting nutrition, specifically in the younger age groups, but also in the older age group, have an impact on decreasing the morbidity and the disability associated with mental disorders and actually prevent mental disorders. We do know that extreme poverty and undernourishment during the critical periods of childhood can have an enormous effect on not only growth and development, but even the development of clear mental disorders in older life. We know that education is a protective mechanism against something going wrong with our mental health. So education for all is extremely important. Enhancing equity, advocating for gender equality, and opposing and taking care of violence are very clear actions which can enhance mental health all over the life. Strengthening public engagement, we do believe that mental health is too important to be left in the hands of specialists. So we do believe that community need to be very intimately involved in planning for their mental health care as well as promoting mental health care. And there are many evidence-based interventions to reduce stigma and discrimination, which have been all-pervading and in all societies. Again, this is not an issue for low and middle income countries, it's an issue for all communities. The stigma and discrimination are common. We have not spent too much time on this here, but the Lancet Commission actually does talk about the specific strategies to reduce stigma and discrimination, which not only are bad in themselves and affect human rights, but are also very clearly a barrier in seeking care. People who feel stigmatized do not want to actually go and identify themselves as having the need for that. And many people actually die because of suicide, because they did not have the courage to go and seek help. So that's something which is extremely important. Engaging civil society in a meaningful manner, and especially involving young people and people with lived experience in all activities, including policy making, service planning, and research. Which is quite important for a place like Harvard. Are we involving some of the people with lived experience in the research that we believe is going to benefit them? And that's something which is becoming increasingly important now for us to be taking care of. And people with lived experience are actually helping us a lot in the launch of the Lancet Commission, and we believe they will take this action forward in a much better way than many professions can. So we are really placing a lot of importance on that. Make more and better investments in mental health. Vikram has showed you the slides which come partly from WHO to say how poor the national financing has been. We do believe that there is need for much more financing, at least 5% of health budget in low and middle income countries, and at least 10% of health budget in high income countries. Majority of countries are far from this level. So even these look like very ambitious targets. But again, let me go back to what I said earlier. It's not only the health budget. We are actually hoping that there will be budgets outside the health sectors which will go into promoting mental health. So that's another story. But also using resources more efficiently and effectively. There is very clear evidence that with this very small budget which countries allocate, quite a large percentage of that goes into mental hospitals, which is a very inefficient way of using the precious resources that we have. So a balanced care and good utilization and effective and efficient utilization of resources is equally important, because, as Vikram said, throwing more money does not mean that we receive more mental health back. And also spending more developmental assistance to mental health bilaterally as well as multilaterally. So organizations like USAID, DFID, and all other development organizations are spending much less than even 1% of their budget on that, and we believe there is need to increase. And also bigger foundations, which have invested a lot of money in health, are still not going into mental health area, and we believe there is need for that. In fact, there is a table in the Lancet Commission which talks about the priorities of the foundations as we see them now, the biggest foundations, and how some of their current agenda could actually be inclusive of mental health without them changing and getting the board approval for a new window to be created. Reinvigorate research based on the grand challenges model to support both discovery and delivery science. We believe both are important. We need more discovery. We need to find out more about why mental health issues come up and also how best to take care of them. But there is a very clear gap between discovery and implementation, and we believe we have the knowledge that we are not utilizing fully. So there is emphasis on delivery science, which again, a place like Harvard can contribute a lot. Understanding early stages of development, developing new prevention interventions, detection of problems early, transdiagnostic interventions, because we know that many interventions are actually effective against many diagnoses, and we haven't had much research on that, including scaling up of care by less trained providers, user technology, and enhancing demand for services, which again touches back on the stigma and discrimination side. We believe that there is need for reframing mental health as a global public good, for including it as an essential component of universal human quality, to be part of health, important for all people in all countries, especially relevant for youth, and also a crucial contributor to human capital. In fact, we know that World Bank is rediscovering the concept of human capital, and it is actually going towards, and we hope they do go all the way, to say, are there other indices besides the GDP which indicate the potential of a country and a society to make rapid progress in the future? And we believe that inclusion of mental health and developmental issues within the index will be extremely useful. So the Lancet Commission, in short, recommends that from no health without mental health, which we talked about in 2007, we go towards no sustainable development without mental health. Thank you very much.
I just wanted to acknowledge the many people who have, taken. These are all the authors, and I'm sure you recognize Arthur as well. These are the organizations that supported us from the beginning, and I think just to say a few words about the public engagement, and then we'll open it up for questions. So this is the announcement for the summit on Tuesday and Wednesday. The Wednesday is when the commission will be officially launched, and when all the products that you will soon you see in a moment about will be available online on a specific website. These are the partners that we worked with over the last 6 months. For us, it's not good enough now to publish in a journal no one reads, but actually to start working with communities that are in fact actively engaging with society. And all of this, Oxford University, they have the most amazing young people's forum in that university that has, for example, brought together 6 slam poets, all young poets from around the world, to write fresh poetry around the commission recommendations. And I've seen 2 or 3 of those, and they're incredible. They also have artists who are doing this, so they're 60 to 90-second videos where the slam poet speaks in his or her own voice their poem. And I hope when you see them on next week that you'll enjoy it. You'll find them quite compelling. I also wanted to say a few words about our own initiative here. As you know, many of you know, we launched an initiative in April this year called Global Mental Health at Harvard, and we're getting ready for the launch to really begin to announce a few partnerships. For example, we're in conversation with a few partners to start an accountability mechanism that can be centered here in Harvard. We are also looking at some other partners around health communication, particularly communicating with development agencies, and a third partnership with digital companies on how to prepare a platform for building capacity for psychological therapy. So really taking some of our recommendations and beginning to explore funding opportunities through strategic partnerships around some of these recommendations. So I'm now going to show you, it's still being finalized. This is an example of one of the products that a company called Global Health Strategies has produced based on the commission. This is their interpretation, and it's like one of these little videos which will be produced. This is not the slam poet, by the way. This is an overview. It's a couple of minutes, and I'll just show it to you to give you a sense of the sorts of products that we will release.
So, why does the world need a commission on global mental health and sustainable development? Because mental ill health is on the rise worldwide, causing early deaths and fueling cycles of poverty. Most people with mental health problems do not receive care, which prolongs suffering and leads to colossal societal and economic losses. Even worse, they are often subjected to human rights abuses and discrimination. To respond to these challenges and help achieve the Sustainable Development Goals, the Commission outlines a comprehensive blueprint for action. This Commission has 3 unique guiding principles. 1. Our approach to mental health covers the full spectrum of mental health, from day-to-day wellness to long-term disabling conditions. We know how to promote mental health, prevent mental disorders, and enable recovery. It's time to use this knowledge to benefit entire populations. 2. Mental health is the product of psychosocial, environmental, biological, and genetic factors interacting with neurodevelopmental processes. Because our experiences in childhood and adolescence shape our mental health for life, it is crucial that these years unfold in nurturing environments, which promote mental health and prevent mental disorders. 3. Mental health should be respected as a fundamental right by putting people living with mental health problems at the center of planning services and challenging stigma. Everyone is entitled to dignity, autonomy, care in the community, and freedom from discrimination. What are the Commission's recommendations? The Commission calls for increasing investment to realize these aspirations, improving services as part of universal health coverage, and recognizing that everyone, everywhere, is entitled to good mental health. These changes rely on a diverse range of groups, from the mental health and development communities to policymakers and civil society, coming together as a global partnership to improve mental health worldwide as part of the Sustainable Development Goals movement. To learn more about the Commission's call to action, visit www.globalmentalhealthcommission.org.
So just to say, this is not live. It'll be live on Tuesday, and you will also see what we're hoping to do is also to have a variety of other products, including a PowerPoint slideshow, which will, and this is something called a GIF. I don't know how many of you ever heard this word. I only heard it now. It's called a GIF. So this is, yeah? How many of you ever heard GIF? Oh, wow. Okay. You were an exception. Sorry. Okay. Anyway, this is a GIF. So as you can see, and there are many like these. So, health coverage is universal only when mental health is included. So the idea is to play on established, words and metaphors, and then to add a second piece of this. So that's it from us. We have about 10 minutes, I think, for questions. As I said, we're all sort of excited about next week, and then the campaign will follow. I should just say the campaign is a very long, it's planned over many months, if not more than a year. There are launches in Lagos, in Lisbon, in Seattle. There's a whole agenda for engagement with translations, etc., etc. So there's a huge community of people who are working, really taking this forward, and it's terrific to see how much of civil society is already engaged with this, making life for the 28 authors very easy. It's like, we've written the piece, and now other people are going to take it away and start doing what they want with it, and that's exactly the way that I think Shekhar and I particularly feel very pleased to see happen. So, over to any questions or any clarifications. Byron.
Thank you for that. I didn't hear, I know that you had to edit this a lot, but I didn't hear you talking explicitly about the benefits of treatment, about what we know at this point about the economic or the ability to work, et cetera. And I would just say, and also then about recovery-oriented care as a basic concept. And I would just say that when I've talked to policymakers, one slide that said people went from being able to work 30 hours a week to 12 hours a week when they developed a mental health problem, and after treatment were able to work over 40 hours a week, that single slide was more convincing to people than anything about the burden of disease, because they're actually interested in whether we actually have, whether the investment actually produces benefits and at what kinds of levels. Is that documented pretty substantially in this report?
Yes, Myron, very good point, and we do have many sections on that, not only in the cost but also on the return on investment, both in terms of the dollars but also in terms of the lost health, which obviously is also quite important. This reminds me of a recent lecture by Patricia, the ex-Minister of Health of Peru, just yesterday or day before, who basically said, we have to change the whole conversation in the area of health, not only mental health, from a spending ministry to a ministry that actually reaps the benefit of investment. And I think that equally applies to mental health. We have things there in the Commission which are saying that message. And also we can develop some more dissemination products around that because the science is there.
Yeah, we also have actually what we haven't presented. You're right. There's a lot of stuff that is in the report which we've not presented. One of which is a fresh modeling of what would be the return on investment for a range of interventions for the prevention and treatment of depression at a population level. What is the investment and what would you get back in terms of things like productivity and years of employment? So you're absolutely right, Byron. That is a very important message.
And Dan Chisholm, who did some of the original work, is actually one of the commissioners. So
yeah.
He has made sure that that line is very clearly kept there.
Please, right at the back.
Thank you. Thank you for sharing all that you did here. You talked a little bit about prevention. How do you think would be the first steps towards prevention in the field of mental health, and how could we reinforce it?
So I'd say the best buys right now is early child development, by far and away. Investing in the massive scaling up of what we know helps promote early brain development in the first. At the moment it's 1,000 days, but it's I don't think that you stop at 1,000 days. That's a little bit of a silo. But really across the early years of life, and as children grow into school age, then also adding the school is another really important platform for delivery. There's a lot of very exciting literature also coming out on school-based interventions, such as building skills for emotional regulation, changing school environments, for example, around policies on bullying. There's actually a lot out there, but much of it comes from other sectors. So, for example, in this university, consider most of the work that I've just described doesn't come from the medical school necessarily, or even the public health school. It comes from the Graduate School of Education. So, the issue with mental health is quite unique in the sense that there are so many different disciplines that are interested in our well-being, and these disciplines have historically established their own particular silos of knowledge, their own journals, their own ways of thinking about the issue, their own audiences, and there has been actually very little real conversation between these silos. And so the idea of convergence is to get us to start thinking about how these different rich disciplinary traditions actually are speaking to one another in a way that is actually quite coherent. They're not, in fact, fragmented voices. They are speaking in a very, very coherent way. So that's what we're hoping for. To the extent to which we can do that is another challenge. Yes, please.
I would support Byron's encouragement to make more of the economic return, because there are several categories of argument one could make here. One is to humanistic values. It's better that people should live well than not well. The other is to professional advice. But the third and Heckman has been especially important in this, in making the case for the economic return. But to pick up the question that was just made, Heckman's argument has to do with the timing of the intervention, as you're saying, Vikram, in terms of the timing and the early interventions paying off. And I wonder, particularly as you're meeting with all these ministers next week, is there a way to draw out that part of the argument more strongly?
So it's a trick, because one has to make sure one doesn't ignore those who are already living with a mental health problem. And how do you, so to be able, that's why, again, it's how we present the dimensional idea in a way that doesn't get a minister to say, okay, fine, we're going to put everything on the left-hand side of that dimension.
Right.
And I know for clinicians would be concerned about that. And that's why we've got the president of the World Psychiatric Association as a key member of the commission, because we absolutely don't want it to be an either-or. We certainly don't want that to be the result of this conversation, and there is a risk that happens. Equally, we don't want people to feel there's nothing we can do about prevention, because I think that is not the case. I think we do know a lot about prevention, at least mechanistically we do, but we haven't really done much with that knowledge. And so,
what's nice about your argument about the balance across the spectrum of intervention.
yeah, well, that's also partly to try and show that depending on which discipline you are, we may be sitting somewhere on that spectrum. But if we step one step behind our discipline or above and look at the whole spectrum, we say, oh, we're connected to the others in this kind of continuum. Teresa and then Myron.
Thank you both. This is amazing and such important work. I'm interested in your thoughts on quality and safety. And one, what you think the big implementation science questions are going forward, and then with this move towards involving more task sharing, what initiatives are required to think about supervision, the quality improvement and safety issues too as you move services into a range of providers?
Let's take Myron's question as well, and then we can see how we are.
WHO through Shekhar has championed MH-GAP, and it's been associated with low and middle income countries. And there was a meeting where there was an opportunity to kind of reflect on trying to scale up MH-GAP. And one of the takeaway messages from that for myself was that the more we talk about low and middle income countries and separate that from high income countries, the more we encourage not me, in other words. And I think the data you presented suggests that when we even talk about MH-GAP, we should talk about it as a universal intervention. It has universal value, not just in low and middle income countries, but in high income countries too. So I'm wondering if we should sort of abandon the distinction of low and middle income countries.
So I'll take Teresa's question, and you take mine. So in response to Teresa's question, which is really about quality of care, this is of course the next holy grail, because we've now shown, to me, it is no longer an interesting question to ask, does task sharing work? It's no longer interesting. It's been done 60 or 70 times, to ask that same, it may be interesting for specific kinds of issues. So for example, let's say developmental disorders, yes, I don't think it's been done 50, 60 times, but if I to say mood, anxiety, trauma-related conditions, I think it's been done enough. The question now is how do we deliver these interventions in a way that can guarantee the sorts of quality that trials do? Because trials, of course, we have an additional investment in ensuring quality, and that is not the case in the real world. So yes, this is not a question that has an answer yet, but we acknowledge that quality is the next frontier, and this is where researchers need to start paying attention to. How can we sustain competency, get people up to competency? How can we sustain their quality after they're competent? How can we ensure that there's safety so that individuals who are not benefiting enough and need to be referred to a more specialized provider, that happens in a timely way? We don't have any of those systems in place, but that is the next agenda for implementation science.
Myron, one of the slides of Vikram actually showed the pyramid of services, the bottom being self-care and community care, that in between being primary care, and the top being specialist care. The pyramid is equally important in all settings in all countries, and even in the high-income countries, the pyramid is usually lying upside down. There's not much self-care, there's not much primary care, whatever care is there is specialist care. So I think, as you are very rightly saying, some of the instruments that have been advanced by WHO, and the Commission does highlight them, are equally important for all countries. And a general doctor and a general nurse in a country like USA or Germany or UK should be much better aware and competent in identifying and treating most of the mental health problems, not all. So and MHGAP is being advanced as a training for non-specialists, but not necessarily only in low and middle income countries. Thank you.
This is a pretty specific question, but I wonder if you have any thoughts about the use of ketamine in treating severely depressed people in low-resource countries. And I'm asking you because ketamine is readily available in low-resource countries. It's fairly safe to give in low doses, and it's not expensive.
So it's a very new intervention, and we do give a nod to this new knowledge, but we don't recommend it because I think it's very early days. There's also issues around safety and how it will be delivered and who. So I think it's for those of us who are clinicians and work in the area of refractory mood disorders, etc. I think it's very exciting, but I don't know whether we don't think it's actually ready for this kind of scaling up. There's so many other things that we know work, but which we're not even remotely delivering. So I think we really emphasize those interventions. Megan.
You mentioned doing innovation and research around the grand challenges model. Can you clarify what exactly that model is and what aspects of it are most useful?
Vikram and I both were involved in 2011 in doing the grand challenges, which was a consensus or other opinions of a very wide number of people to say which are the grand challenges in the global mental health area. And a paper was published in the Nature in 2011, which described 6 grand challenges out of 25 which were rated, and some of them are essentially about the dissemination and implementation science. So the Lancet Commission makes a recommendation. In fact, there is a table there which says under each of these, which are the questions which are top of the line for research and innovation. The Lancet Commission also emphasizes the need for innovation, which are actually happening quite a bit in the low and middle income countries, and they have relevance even for high income countries. So it's not a one-way knowledge transfer, it's a much more now multilateral knowledge transfer. So that's something which is emphasized quite a bit. But I'm happy to share with you the grand challenges framework as well as the table which is there.
Okay, I think we've probably hit the Scott.
Yeah. This is wonderful. Thank you both very much. And good luck next week. I hope we've prepped you for next week. And we're all
We just have to pray the UK government doesn't fall by then. That would be the worst thing of all after all this preparation, because they're teaching at the moment. That's the only fear that I have.
Yeah, good luck to both of you next week.
Thank you.
Thank you.
Thank you.
I have one request. So I know you want to say hi. Yeah. Still love it.